Welcome to the November 13th, 2013 meeting of the Suburban Detroit Trigeminal Neuralgia Support Group. We have Dr. Vallerand with us. He'll be here shortly. I told him not to worry if he wasn't here right away because we have a number of other items on the agenda to cover. Just his background, I'll probably say it again when he's here, but if you have any questions ahead of time, he's an oral surgeon, an MD, and a pain specialist, and he's been involved in trigeminal neuralgia from the start of the organization back in New Jersey back in the mid-90s. His wife was on the original medical advisory board of the TNA because she's a PhD nurse in Wayne State. I don't know, they were living out east at the time, so they can flare. And so he goes way back to that. Again, he mainly deals with the constant pain or the atypical form, but if you got any questions on typical, I'm sure you can answer those as well. It's just that his particular area of, that he works in now is more the atypical, and a number of our people have gone to him over the years. I've probably sent 50 to 100 people to him over the years, because we've run it now 16 years. For your information, Dr. Casper, we've been running 16 years now. And by the way, Lynn Rupie is the co-leader here. She's an RN and has a dental assistant experience. So she's been the co-leader with us for at least the last 10 or 12 years. And we were in the original group together down at the Detroit Rehab when they started it down there. Hello to Yoko in Japan, from Lynn as well. I said I would say hi to her every time. She picks us up in Japan. Again, I talked about Dr. Warren Vallerand. He's our main speaker. He's, I think, Miss Brownlee, Joyce,
yes,
you would agree with my statement that he's one of the most understanding medical professionals that we've ever met.
Very much so.
Yeah, very empathetic, because he really, although he or his wife haven't had trigeminal neuralgia, they've dealt with so many patients over the years. They know how severe it can be and how much it affects our lives. I mentioned I had an 89-year-old lady called me this afternoon, and she just heard about our group through my eye doctor, Dr. Clavina, if anybody sees him here in Birmingham. And she's had it for 4.5 years, never heard of our group, and said, oh, doesn't it really affect your life? The same thing you just mentioned to me, it really affects our lives. And so we're going to get her in to see one of the neurosurgeons probably. She's probably more candidate for the gamma knife as you discussed. Are there any new members here that haven't been here before? I always want to say that one of our most important items are the new member introductions, where new members, usually when they come, it's the first time they've ever talked to anybody else that's had this condition. So I look to that as one of the most important items we've got. When we have speakers, we normally don't have a chance to get around to them. So what we've tried to do is alternate speakers every other month, although I haven't kept to that rule this fall. We've had speakers September, October, November. But we usually try to leave one in between where we can actually spend more time with the new members. We're going to hear from Gary Goodman, who's running the camera for all those of you at home here in a minute, who will discuss his successful MVD by Dr. Malley. I have a couple of other notes after you speak, other people that have had it by Dr. Casey, Dr. Piper, and Lynn's here with Dr. Piper, for Dr. Piper. I really kind of wrote this. Priscilla out in Denver, who's putting this video on the internet now on the TNA website, is also posting our letters and our, well, there it is right there. See the facepainhelp.com. That's where you would go for the video. You were asking me about it right here. It comes out a little dull, but facepainhelp.com. Maybe we can gin up some business for our local neurosurgeons, who knows. But, you know, we've had one lady, I know Kim Stump went to Pittsburgh, and hers is starting to come back. The lady who started the TNA group initially, Pam Bishke, went to Dr. Janetta twice, and both failed. So, and maybe the circumstances were wrong at the time. Maybe she shouldn't have had an MVD, who knows. Usually people that have this pain, if they get in front of a doctor, they'll say, give me anything, I just need help. So maybe she shouldn't have had an MVD in the first place. But we do, for those of you that are viewing this at home, we have 3 or 4 excellent neurosurgeons in our midst right here in the Detroit area, if you're looking for someone to do an MVD or the gamma knife. This other thing I just picked up, and Lynn informed me it's for female hormones as well. I guess I didn't read the article.
Yeah.
Males too, is that it?
Yeah.
It causes labor.
Yeah.
Oh, is that it?
Yeah, so we used to induce women in
Yeah.
labor.
Could I lose 50 pounds?
And also stops the uterus from hemorrhaging afterwards.
Oh, really?
Yeah.
Oh, are you a nurse?
Yes.
Oh, okay, forgot about that, yeah. Well, that's good to know. Have all of you, I hope, you received the quarterly?
No, I did not.
You don't get that? You don't get that? You must, have you given anything to TNA at all? I understood way back when somebody else was running the group that they said they keep you on distribution for a year or so, and then if people don't contribute, maybe they drop. Maybe that's what happens. You got yours, all right?
I did.
TNA quarterly. This article in here, if anybody wants to read this or have me send you a copy, it's like 6 or 7 pages long. That's why I didn't attach it to the agenda. But it's, did you read it yet?
It's all online.
Yeah,
Is it online?
Yeah.
Oh, okay, you can get it online. Good to see how fortunate I am to have a good co-leader who looks at the TNA website every now and then. But I thought it was an excellent article. It just covered everything. And I thanked Cindy for it and said she did a great job. And as Cindy would usually say, I didn't write it all myself. You know, she wouldn't take credit for it. For any of you who have been to a TNA website or a TNA conference, you would have met Cindy itself. 7 classifications. Oh yeah, she covers all of the how you should try to get a second opinion, patient rights. They do 7 new classifications for facial pain, a doctor's perspective that we must keep in mind when I say carrying our story. We need to know that some neurosurgeons or doctors have had a bad day just like we could, and if they don't listen to you one day but they do the next, it could be that they just had a bad day. One thing in that I was going to cover. Anyway, going against my thought of having a second opinion, Kathy LaForest was here when Dr. Casey spoke in September, and wham bam, she went and had an MVD with Dr. Casey, and she's pain-free. So that goes against my theory of you should get more than one opinion. She was a good friend of Jill Lighthizer. If I said that right. Yeah, was a good friend of her mom's. And she sat in, first meeting she sat in, she listened to Dr. Casey, was so enthralled with his talk, she went down there, had an MVD, and she would be here now, except she doesn't like to drive after dark and in the cold weather, so she'll be here in the spring and tell us more. She had it by Dr. Malik as well, or by Casey. Somebody else I'm thinking of had one by Dr. Malik. I'm getting in front of your talk, Gary. No, this was from Kathy, sorry. There's somebody else that had one by Dr. Malik too that I'm forgetting. And as we know, we had 4 here about, what was it, 2 years ago this month, I think, when you and...
3 years.
Has it been 3 years? Lord. We had 4 ladies here right in the front row who had just had the MVD by Dr. Piper the month before, and it was only 2 or 3 weeks later, and they were all sitting in the front row with smiles on their face. So. Again, we have Dr. Guith down at DMC, Dr. Malik at West Bloomfield, Dr. Piper here, and Dr. Casey downriver. Unfortunately, we don't have Dr. Copeland anymore, who I advised you a month or so ago that he passed away. He was in Midland with the gamma knife. Did you know Dr. Copeland? No. Yeah. Did you? Did you know he passed away?
No, I did not.
Yeah, I'll tell you the story later.
Mm-hmm.
Yeah, I see him. I'll be with him in just a second. I did complete a financial analysis after about 3 years, and the good news is it's supposed to clear up. We are in the black. Yeah, I know it. It usually clears up, mainly due to
Arabic.
yeah, Arabic. Two $500 contributions we received from a expert. What do I do to get this in? I don't know why the second page isn't coming out. Anyway, 2 $500 contributions, I think 1 in 2009 and 1 in 2011 from the Gamma Knife Center here at Beaumont. So we are in the black about $400 or $500. So I didn't want to say that too loud because we want people to continue to contribute. You never know when we'll go back in the red, which we were for the first couple of years when we started out. The meetings run anywhere from, $80 to 110, if you can believe it. We mail to 110 people. We email, which is no charge, to about 150. If you get it via email, you're only seeing 1 of 4 that go out. My system will only allow so many twos, or whatever you call it, recipients. So I have to send it in 4 waves. So you're just seeing like 1/4 of the group that we email to. But again, we found out here lately that we still have a number of people that we're not getting to. So please don't let up the verbal, you know, whether you're talking to your neighbor or somebody else. We find so many people by word of mouth. And timing is just right because Dr. Vallerand has arrived in the back of the room. You can cut that, Gary.
My name is Warren Vallerand. I guess Tim already introduced me. I am a practicing oral and maxillofacial surgeon and a physician. I practice over in the Novi area. And most people, when they hear, you know, they hear my credentials, they say, "Oh, you're an oral surgeon. You're the guys that take out wisdom teeth and put implants," things like that. And I said, yeah, that's pretty much that's the basic core of our training. We're also trained to remove facial tumors and head and neck tumors and deal with facial head and neck trauma. And depending upon one's training, end up in various areas of niches of expertise, if you will. I had the, depending upon how you look at it, the good or the bad luck of training, doing my surgical residency back in the early 80s, when at that point what was really in vogue was treatment of TMJ, or temporal mandibular joint problems. I'm sure you've all, at one point or another, heard of people saying, "Oh, I think I have," you know, any of you who have TN, probably at one point were told, you might, either you have a toothache, or you have an earache, or you have TMJ. Yep. And you went from dentist to ENT doctor, and at some point, some dentist put his finger on the side of your ear, in front of your ear, and you did this, and it clicked, and he goes, "Oh, you've got TMJ." And they sent you on your way, and you say, "Well, what's TMJ?" Well, anyway, that's not, I could talk several hours on what TMJ is and what it isn't, so I'm not going to go into that. All you need to do is just, you know, I'm sure you all are very, you know, those of you that have TN, and especially those of you that attend these meetings, I'm sure you're very savvy with doing searches on the web. You just enter the acronym TMJ on a Google search, and you'll spend the next 6 days just wading through the first 3 pages of results. Anyway, I got sidetracked, as I often do if I don't take my Ritalin. Look at cats. Sorry. Anyway, a lot of people got surgery for quote-unquote TMJ problems in the 80s because that was what was in vogue. If your joint clicked a little bit, meaning your jaw joint, and you had some pain in your face, obviously you needed surgery. So the joke was, when I did my residency and my fellowship, and at that point you're basically, you stand at the right hand of the department chairman, who was, you know, he was like the, when anybody wanted TMJ surgery in Florida, that's where they went to see this guy. And as his chief resident, you basically dealt with all the problems that he didn't want to deal with. Everybody who needed surgery, got surgery, did well. They were the ones that got, you know, they were part of the dog and pony show who got trotted across the stage saying, "Look how fantastic these people did." Everybody else, basically that's what the resident and the fellow took care of. The people that might have needed surgery but maybe didn't, or needed surgery but didn't get a good result, or needed surgery and got a bad result, or maybe didn't need surgery at all, but either way, we identified this larger and larger growing group of people that had pain, either because they had surgery or maybe they hadn't, but they had pain, and when they went to see their primary care doctor, if they were lucky enough to have a primary care doctor who knew what trigeminal neuralgia was, that already took, you know, you take 100 doctors, that knocked down about 5. So you had 5 doctors that knew what it was, and if they were lucky enough to have the 1 out of that 5 that knew what the classic signs and symptoms or classic TN was, you know, they had that one doctor and say, "You don't have that." And they said, "Well, thank you very much. What do I have?" And you go, "Oh." You shrug his shoulder, and what you'd end up with is and what I ended up seeing, both during my fellowship and during further training, was a larger and larger growing group of people who didn't have a TMJ problem. Thank God hadn't had a scalpel put in the side of their face to fix a TMJ problem, but had facial pain, and it wasn't lancinating, it wasn't one of those touch here, oh my God, it's a lightning bolt shock, and their doctor said, aha, you have trigeminal neuralgia. I learned about that in medical school. Again, if you had that one doctor. If you didn't have that one doctor, your doctor said, I don't know what it is. But anyway, you know, joking aside, a lot of patients, you know, I see quite a few patients. I don't want to say a significant part of my practice is treating patients with facial pain, and every couple months, I'll see a patient who actually has misdiagnosed classical trigeminal neuralgia. They're few and far between, unfortunately, because more often than not, what I see are patients who have, you know, not missed but undiagnosed atypical TN, because it's like, I don't know what it is. You know, their doctor said, I don't know what it is. It's not a toothache, and it doesn't click, so it's not TMJ. You went to see your dentist, and your dentist says it's not TMJ, and your ENT doctor looked in your ear and said it's not an earache, but it's there all the time. It's not just when I touch here. It's burning sometimes. Sometimes it's stabbing. Sometimes cold brings it on. Sometimes heat brings it on. There's no rhyme or reason to it. And I don't know. I see some of you nodding, so some of you are probably kind of familiar with this. I'm not going to spend time defining what ATN is. I mean, Kim Dershiel can do that the best. There's like 7 different subcategories now of it. He is like one. I respect him more than anybody else as far as being able to, you know, take things down to the nth degree, and whether it's typical, atypical type A, B, C, subcategory C or D, I get lost. I'm not a neurosurgeon. I am a surgeon, but my treatment for the patients that I treat with atypical facial pain or atypical TN, for the most part, is medical management, which is how I ended up at one point, you know, in my midlife crisis, going back to school and going to medical school, because I realized that although I've been trained as a surgeon, a lot of patients with atypical facial pain, the last thing they needed was what we like to refer to, you know, in the surgical lounges, cold steel, fresh air, and sunshine. That's how we fixed everything. You know, if it didn't, you know, work, if it was broken, cut it out. Well, the problem is everything can't be fixed by sticking a knife in it, whether it's a stainless steel knife or whether it's a gamma knife. Just sticking a knife in something isn't going to fix it, just for the sake of fixing. If you can't see anything, well, we'll cut it out. I mean, to some degree, the same thing goes for cryotherapy or alcohol ablation. Well, the pain's coming from there, so we don't see anything there, but that's where the pain seems to be, so let's just burn it or freeze it and see what happens. And any of you who've had that done, or as a family member had that done, knows that, yeah, sometimes it works for a while, and sometimes it doesn't. And if it worked for you for a long time, God bless you, stick to it. Because the last thing I'm here to do this evening is to say what to do or what not to do. Or to say, you know, if something worked for you, then God bless you, stick with it, because I know how desperate you all are or can be. I know I had the opportunity to see a patient a few years ago, about 2 years ago, about a week before she committed suicide because of her TN pain. And seeing this patient in my office, you know, cringing and sobbing, and being able to tell her, I don't know what to do. I can't do anything for you. So I don't want to say I understand, because I don't have the hell you go through, some of you go through, but I can empathize to some degree. So anyway, let me stop getting watery-eyed and tell you, what am I here to talk about? Am I here to meander? No, I'm not. Well, I'm not going to talk about surgery. What I am here to talk about is the KISS principle, you know, the one I'm sure you're all familiar with, the keep it simple, stupid principle. The way I manage, or the way I like to approach TN or ATN, is to simplify things as much as possible. You know, Tim asked me for a title of tonight's presentation. I just said, you know, treatment of ATN. I've brought in slides before showing all sorts of listing the drugs, listing the medications, and I don't see a need to do that, because I could sit down in the back and you could all tell me more in 30 minutes about the various medications and what their side effects are, which ones work and which ones don't work, than I can. You know, your combined experience, you know, far exudes mine. So I guess the issue is one of, what do I do? What insight can I give you? And I think I've said it when I've spoken to this group before. I like to simplify things. What I'll just want to briefly run through is what I do when I see a patient with TN or ATN, or facial pain for that matter. We haven't categorized what it is, because that's what differs. You know, we all differ. You all know the conditions. I don't need to tell you what the condition is. The patient will usually come to see me because they've got facial pain. And all the easy stuff, if you will, has been ruled out. It's not a toothache, it's not a sinus infection, it's not a clicking jaw joint. So then the question comes down to, more often than not, you know, where is the pain? Where is it located? How often is it there? Does something make it better? Something make it worse? More often than not, the list of things that make it worse, or there's a laundry list, things that make it better, you could put them in a matchbox and they'd rattle around. There are a whole lot of things that make it better. And my goal, or you know, the goal that's, you know, the expectation that my patient has is, I'm going to fix that. You know, I'm going to change it. I'm going to be, you know, the great hope, and I'm going to, you know, take a little magic wand out and tap you on the head. And as you all know, you've all seen at least one specialist, if not more, you know that it doesn't always happen. So the first thing I will tell any patient when I see them for the first time is, once I get kind of wrap my head around what's going on, is I don't think I can. I know I can't cure you. If we could cure this god-awful disease, we would, and we'd all be happy again. But since we don't really know what causes it, the best we can do is treat the symptoms. So my goal is going to be, and I'll say the same thing, I can't cure you, and I can't guarantee you I'll make you pain-free. All I can guarantee you is that I will do, my goal will be to improve your quality of life such that you feel better under my care than you did not. That doesn't mean the doctors you've seen before me were bad doctors, didn't mean they weren't doing a good job, it just meant that I'm going to approach it different. And that may not even be any better. You know, I'll be the first to admit, I've seen a lot of patients who've come in, I've treated them for weeks or months, and they leave saying, I'm not any better, doctor. I'm sorry, you know, did what I could. But to back up a few steps, keep it simple. Simplify it. So you tell me what the symptoms are, you tell me where the pain is, how often is it there, how bad it is. From 0 to 10, where is it on average? Where is it at its worst? What is it like on its best day? Do you ever have any best days? How often do you have those best days? Then we just look at all that data. And then the most important part of the way I approach this is detective work, and that's to find out what has worked. What has worked in the past for you? And by that I don't mean, you know, to take the pain away. If it did, you wouldn't be here. So obviously, did it help a little bit? And if it did, okay, great. Why aren't you still doing that? And if there's not a good reason for still doing that, we put them on the list of possible things to try. Make the list also of the things that you tried that didn't work. Come hell or high water, you're not going to do that again. Say, yeah, doc, I was on the run. Did it work? Oh, it worked fine until I put on 40 pounds, and when I walked, I couldn't feel my feet, or I felt like I was a zombie. So then what did they do next? Well, they took me off the run and they put me on Lyrica. That worked, didn't it? No. They took the dose, we went up as high as we could on that, nothing happened. Everybody says, oh, if Neurontin didn't work for your side effects, I can guarantee you Lyrica doesn't do the job. Unfortunately, it doesn't always. It doesn't always, unfortunately, as I'm sure many of you already found that out. So you then come down to one of, you go from the basic, the standard trench warfare medications, the Neurontin, the Tegretol, the Gabapentin, the Topamax, whatever you've been on, and then we start, or the doctor you've seen previously, start piling on other medications. Well, we'll try this and maybe this. And again, I try to pare things down to simply, okay, let's talk about the medicines you've been on. Okay, Tegretol, were you on it? Yes. What was the maximum dose you were on? What was the minimum dose you were on? Did it ever work? Did at any point, did it work? And something happened to make you stop using it. With any of the medications, it'll be anything from reasons for stopping. More often not either the side effects or it didn't work. Those are the two main reasons. And more often than not, a lot of the medications that I see, especially Neurontin, patients that I see who haven't seen a neurologist, or who see a neurologist who doesn't really treat a lot of TN, but if they come from the primary care doctors, the reason is they weren't on a high enough dose. Meaning, why did they stop? Well, it wasn't working. Well, why did they stop getting side effects? No, the doctor just said it couldn't be any higher. Okay, well, yeah, there's a maximum dose. Back a couple of years ago, the maximum dose was no more than 800 milligrams a day. Now it's a couple thousand milligrams a day. It's whatever works. But the secret to any of these medications you know, at least in my hands, is we start at a very low dose and we move up very slowly. And that frustrates a lot of my patients. It's like, doc, I want this fixed now. You know, why don't we increase the dose quicker? And my response is, how long have you had this pain? 10, 15 years. Can you give me a couple weeks then? You know, I know I'd like to, you know, let's bump these doses up real quick and the frequent with pain go away. And what'll happen is if we bump them up too quick, you're gonna call me the next day. You're not gonna call me the next day because you're gonna be such a zombie, you won't be able to find the phone. So we start with a low dose, we move it very slowly. You probably all experienced that with at least one medication. So the way I treat is first thing we'll start with a basic medication, and then this is where things get, some patients get frustrated. I'm not a big fan of starting patients with TN, or ATN, on multiple medications at one time. Because the problem with that is that although it seems more promising, if you get relief, that's great, but if you get side effects, then it's which drug caused it. And what oftentimes will happen is patients say, I was on Tegretol, and I was on Klonopin, and I was on Ambien, and I was on Baclofen. What happened? I was a zombie. So what they do, they just took me off everything except the Tegretol, because the Tegretol was helping. You don't know that. So, and, you know, any of you that have been treated, you know, I would hope the initial approach was starting with something basic like Dilantin or Tegretol, Neurontin, escalating the dose to some point, and at some point saying, well, maybe we should add some sort of adjuvant agent. There are some people doing work that they'll say suggested some of the SSRIs, some of the old Prozac type drugs might help. They've never really been shown to. Some of the selective norepinephrine reuptake inhibitors, all the various antidepressants. There's work being done, but there's no hardcore evidence that says any of them will help a lot with ATN pain. One of the most frustrating medications I see patients occasionally prescribed for treating their ATN pain is Klonopin, clonazepam. Because somewhere along the line, somebody said, well, it's kind of an anti-seizure medication, so let's use it for that. And I see so many patients, frustratingly so, on the medication, and it doesn't really help their pain. It does a great job for their anxiety, but it's also hell to get off if the patient or the individual wants to get off of it. It's a very long-acting, long-lasting Valium-type drug, and it requires a very slow, prolonged withdrawal from to take patients off without them feeling yucky. And by yucky, I mean anywhere from nauseated to flu-like to having a seizure. I'd really rather not have patients seize. Most patients would rather not seize also. So that if I'm going to say anything, then again, this is just purely my preference. I'm not a big fan of Klonopin. So if you think that's going to be the magic drug, don't call me. I don't want to know about it. I mean, if you call me, I'll be happy to talk to you. But we'll have a light discussion over it because I've never seen any real strong data that says that Klonopin or the sleepers, Ambien, any of the benzodiazepine, Xanax will really help chronic facial pain. They will help the anxiety with it, but they're not necessarily going to help your pain. And as I said a few moments ago, my outset, the goal of treatment that I have for patients with ATN is maximize your functional status while keeping your pain as low as we can reasonably, and always having to balance between side effects and pain relief. Because I've had several patients that learned over the years, by the time I inherited them, that the best way to get pain relief was essentially to be comatose, because no one ever really made an attempt to try to balance those. And I can't always fix that. I tried. I had one patient lady I'm still working with trying to back her back down from doses of Klonopin that would choke a horse. But she's so, the need is there, and it's tough because I'll have patients that'll say, what I really need when I'm having a lot of pain is I take a lot of X. What does that do? It makes me go to sleep. Well, that's one way to deal with the pain. I know what that's like now. I'm suffering with some major issues with the lumbar disc disease. I know what it's like to just be in such bad pain that I just want to go to sleep because nothing else works. But again, I can't say that is anywhere near the magnitude of the pain that some of you suffer from. But I'm sure most of you would rather have some ability to function with your pain relief and not just, sleep through life, because we're all going to sleep eventually, but let's stay awake for the good stuff before that happens. So start with the basic medication, start on a low dose. Make a list, and again, these are things I'm telling you to do. This is purely my approach to things, and if you want me to say something else or something that's beyond me, interrupt me at any time. So I'm not here to list medications, not here to tell you what to do, what not to do. I'm just telling you my approach to it, and I found that it's what I've stuck to for 20 some odd years. And for a lot of patients it works, for some patients it doesn't. And again, for most patients it achieves the goal that I set out, and that is to hopefully get, maybe 20–30% reduction in the overall pain. Is that fantastic? No, but it's better than a sharp stick in the eye, which is what some ATN pain feels like. So we'll look at the medications, look at the ones you're on, list the ones that have been tried, list the ones that you've been taken off of for whatever reason, and then see, is there anything that hasn't been tried? And then look at possible combinations. Again, if I have a patient who's on multiple medications, we make adjustments. We adjust one drug at a time. We don't adjust multiple drugs for the same reason. If I increase the dose of the Neurontin you're taking and increase the dose of phenobarb you're taking or whatever, and you start getting nauseated, which the two caused it. I don't remember much of multivariate calculus from college. I don't want to try to remember it. I'm a big fan of moving one variable at a time and seeing what happens. Again, the standard basic medications are always out there, the anticonvulsants, membrane stabilizers. Then there are other things that need to be thrown into the mix, which oftentimes aren't, interestingly enough. Some of the strangest medications people don't try or haven't tried oftentimes work really well. Not by themselves, but in combination. That's just simple things like Tylenol, or aspirin, or Advil. Ask the patient to take Advil. Oh no, why did I do that? I tried that years ago when this first happened, and it didn't work, so I stopped. Well, it's not necessarily going to. The pain that you all experience, that the patients I see experience anyway, is so multifaceted. I say, well, it burns, sometimes it stings, it throbs, it aches. It feels like this tight, clamping vice, and usually it's going to take more than one medication to ease off those symptoms. And again, any one isn't going to do it entirely. It's usually going to be some combination of them that'll take care of this kind of the pain or that kind of the pain. Again, I have a patient who he constantly describes having this standard, what he calls facial pain that's always there, and that we deal with using a combination of Tegretol, Dilaudid, and Duragesic. But then he also gets what he calls these eye attacks back behind his eye, which he swears the only thing that works for that is a Klonopin. And so we have issues with that. We go round and round with that. But what I'm trying to get at is that multiple medications can sometimes deal with some of these factors. I have several patients that are on very, very low doses of some opioids, and they say that takes care of it the majority of the time. So what happens when you have a bad day? So I take a couple of Tylenol, and that makes a difference. Again, there's nothing magical about Tylenol or Advil or any of those. They just will attack one aspect of the pain that another medication won't. Look at Tegretol, look at Neurontin. The way they work is they're essentially anti-seizure drugs. They deal with affecting the way nerve fibers work electrically, the way they fire. They make a short circuit essentially be not so short. They take something that's flashing constantly like a neon sign and they slow it down. Drugs like Advil, aspirin work entirely different. They stop the traditional pathways of inflammation, which are an entirely different type of pain. Tylenol works in entirely different ways. It appears to have some anti-inflammatory effects, but nobody's ever really been clear to show exactly where it works. We do know it doesn't work where Neurontin works. It doesn't work in the same area where aspirin works. So why not try those in addition to or as alternatives to the other medications? If any of you, I was thinking of a silly analogy on the way in here, would have loved to have brought in, a CD that had just the sound of, one violin playing versus a quartet versus an orchestra. Your pain is kind of like that. Or most people, there's so many components to it, and not one drug will necessarily take care of all of it. You'd actually take one pill, it'll all be gone. But it's managing multiple factors of it. And again, the one take-home that I can suggest you all want to consider trying, if you're in the mode where you do some of your own self-management. That is, if you haven't tried things like aspirin, Tylenol, or Advil, as long as they're medications you've tolerated in the past, as long as they're medications that your physician says you're okay taking, because obviously if you're taking Plavix because you had stents put in, or you're taking Coumadin because you've had deep veins thrombosis, you probably shouldn't be taking aspirin or Advil also. Same thing if you have a massive GI ulcer, I don't want you taking aspirin, but talk to your doctor and see. More often than not, they'll say, heck, if there's no reason not to, give it a try. There's nothing, it couldn't hurt, as they say. So that's the one, the one quirky thing I'll throw out there, the one alternative. I want to try to have you all walk away with, something in your little take-home goodie bags, and that would be the one thing, to try some of the simple stuff that's out there. I'm sure I don't need to tell any of you the idea of what works better, heat or ice. What works better is whatever works for you. There's no magic. You got to use ice, then it'll work. Got to use no, it won't. And sometimes one will work better than the others. And it's frustrating as all hell to have to rotate between one modality and another. But the one thing I encourage all my patients to do is to experiment. I'll give you your prescriptions, I'll give you your medications, I'll give you your ranges. As far as ranges, doses to try, have at it. You know your pain better than I do. I'm not going to say you have to take this medication, you have to take it at this frequency. Patients come in and say, well, doc, I've been taking my Neuron the way it was prescribed. 200 milligrams 3 times a day. What happens? Well, it works most days. What do you mean most days? Well, some days I need to take an additional one. Well, that's okay. What do you mean that's okay? Well, that's okay. Why don't you? And sometimes they say, well, the bottle says, 1 3 times a day. Can I take? Well, of course. The first thing I'll say is, we're going to start you on that. Feel free to take more up to you. If you need to increase the dose, you're going to call me first. But also don't feel the need to, very classically I see with patients with a Neuron, they'll say, I get a real good relief, but if I get more than, say, 1,000 milligrams a day, I start getting sleepy. So say, fine. If you're going to take, how are you taking those, times a day? Fine. You want to take an additional dose? Take it before bedtime. It'll help your pain, it'll help you sleep better. Nobody says you have to take it all throughout the day, because if you do and you're sleepy, it's really okay, to load the doses, take 1 in the morning, 1 midday, then take the rest like at dinner time or bedtime. So it's okay to do that. Most of the drugs like that, they're in your system for some prolonged period of time. They don't have to necessarily all be spaced out, to some degree. So you've got some flexibility there. So like I said, I'll tell my patients, feel free to experiment. That is the timing and decreasing quantities within reason. Increasing, I always want to hear about it first. But you'll find I'm a pretty benign parent in that regard. As long as you tell me what you're doing, I'm fine with it. Because as I said, you all know your bodies, you all know your pain better than I do. Any physician who tries to tell you that they're an expert on your pain, I wouldn't want to listen to them, because the only person who knows your pain is you. So I'll just talk briefly about the last thing I have to say, then we'll open up any questions you all might have. And that is,
Doc, let me just interrupt for a
yes,
second.
Appreciate the offer. That's opioids. I always wrap up with that, just because it's kind of it has been. What's interesting, for the longest time it was a no-no. You did not use opioids or narcotics, if you will, for chronic non-cancer pain. Then several years ago, God, it's been years ago now, so maybe 5, 10 years ago, the pendulum swung the other way.
Sorry, Doc, go ahead.
George Stephanopoulos.
Yeah.
Years ago, and it seemed like, for the longest time, it felt like yesterday. Years ago now, it's been like 10 years, the idea is, doctors are being sued for undertreating pain. You've got to do a better job of treating pain. And that got us to where we are now, and that is the doctors are prescribing too many opioids. That's what caused, it was doctors, inappropriately overprescribing opioids that led to the massive overuse of OxyContin and medications like that, and led to the hillbilly heroin highway leading down all the drug clinics in Florida, where you could walk in down there, say you had chronic pain, and walk back with a prescription for OxyContin, drive to Kentucky and sell it. And the pendulum is now swinging the opposite way towards the jackboots kicking in the doors. Hopefully it'll come somewhere back in the middle again. But I still, opioids do have a place for chronic pain treatment chronic pain in some patients, not all patients. It's not a panacea, it's not a fix-all. I've seen a lot of patients who come in and say, I'm here specifically because I want drug X or drug Y for my pain. I say, okay, that's interesting. Why do you want that? Well, because, Mr. Smith or my friend Fred or somebody talked to mine said it worked for him, therefore. Some do. Some patients get relief with it. But the proper approach with opioids, in my mind, and most, I think, a rational approach is that they are used as part of, again, a multi-drug regimen only when you've tried other medications exhaustively. Not to say, oh my God, it's a drug of last choice. No, I'll certainly entertain the idea early on, but to be taking opioids and not be taking an anticonvulsant of some sort, or not, to be taking some sort of a chronic anti-inflammatory drug, opioid, there's an order things are done in, and you don't start with, I've got TN. Good, let's get you started on some Duragesic then. Doesn't work that way. When I spoke here before, one of the cutesy topics I would call this topic is, my talk would be rationale, the difference being letter E, rational rationale for treating chronic TN pain. Because the rationale being the plan, but there's got to be some rational idea behind it. And just like any other medication, just because one didn't work doesn't mean the other won't. Now, when we talk about opioids, some patients, for whatever reason, do exceptionally well with morphine. Others can't stand morphine and find they get fantastic relief with Dilaudid. Same thing goes for things like hydrocodone, which is the key ingredient in drugs like Vicodin or Lortab, and oxycodone, which is the key ingredient in drugs like the devil's spawn, OxyContin. I say that jokingly because I actually at this point, among the numerous patients I'm treating for chronic facial pain, I actually only have 2 that are actually doing well on OxyContin. A lot of patients that were on it today have taken them off of it because of the concerns. Same thing goes for Lyrica. No, I'm sorry, not Lyrica, I'm sorry, Actique. I know, does anyone here have been prescribed or using Actique for the pain at this point? Okay. I backed off of prescribing Actique very rapidly when the feds started getting really, really upset about it being used for non-cancer pain. Therefore, should it not be used? Should you not be taking it? Absolutely not. If it works, it works. If it works for you, nothing else does, then God bless you. Take it, use it.
Express Scripts won't let you have it unless you have cancer.
Absolutely, absolutely. You've got pain and you have medication that works, then God bless you. I was fortunate that 2 or 3 patients I had that, I hadn't started anyone. I had inherited patients, if you will, that were on Actique, and most of them was able to find a substitute for. The same thing goes. The next one line that's going to be, real quickly. That everybody has in their sights are the Vicodin and the Lortab drugs. Because Vicodin has just gotten such a bad name. It's like the drug of abuse these days. Not just among teenagers who are taking out of mom and dad's medicine cabinets, but the bad doctors like myself that are prescribing it. The biggest problem I have with Vicodin or Lortab is that no one has yet come out with a form that's just has a pure opioid in it. It's a problem with Lortab and Vicodin. The active opioid in that drug is hydrocodone. And to make it turn into Lortab or Vicodin, they didn't add some Tylenol to it. And so what always makes that drug, gives you a maximum dose that you can take on any given day, is how much Tylenol there is in it. It's not the hydrocodone that's in it. The one thing, if you probably haven't been told before, is that all of the opioids, whether it be morphine, Dilaudid, oxycodone, hydrocodone, codeine, there is no maximum dose above which you don't go just based upon a number. It's not like, oh, you can't go above 2 grams because it'll destroy your kidneys. No, the maximum dose for any opioid is either that which gives you relief or that which causes side effects which are intolerable, meaning constipation, sedation, stopping breathing, dying. So there are some, but there is no numerical limit among which you stop. Gosh, I don't know how many patients I've seen that'll come in on, literally hundreds of milligrams of morphine a day, and they had a family member say, you can't be on that much. Why? You just can't. Because my doctor said that's too high. What'll happen? Well, you're going to die. Well, how did you get it? Well, I drove here, I'm breathing, I'm coherent, I can calculate my times tables forward and backwards, but you can't be on the drug. Well, I'm sorry, I am. It makes it fun. There is no, the maximum dose is that, just like I said, it takes me back to where I started, and I'll stop. And that is, maximum pain relief with minimum reduction in function. Any of those medications, I can take a dose of high enough and you're going to be fine. You'll be happy. You'll be sitting in a chair stoned, holding the garage door opener, thinking it's the remote control and wondering why the channels are changing, so you'll be pain-free. And I know that's not what you're here for. But as I'm saying, opioid, just like the anticonvulsants, the other drugs, some work for some patients. Just because your friend gets good relief on OxyContin doesn't mean you will. Just because they're having side effects of hydrocodone doesn't mean you will. Which means just like any other medication in the regimen I'll prescribe, say, okay, fine, what have you tried? Why did you stop taking it? Okay, what can we try differently? And we'll make a little grid. We'll say, let's start on drug X, we'll start on a very low dose. Let's go up from there and see what happens. And then work through the various parts of the orchestra. We'll try an anticonvulsant, then maybe we'll try a membrane stabilizing agent, and maybe we'll try a tricyclic antidepressant, something like Elavil, and some combination work. This is not a one-size-fits-all disease, I'm sure you all know that. Good, hand raised, so I'm going to be quiet.
What did you say about the membrane?
Well, I double spoke there. A membrane stabilizing agent is anticonvulsant. One and the same thing. I'm sorry.
Okay. Thank you.
The way an anticonvulsant works is by stabilizing the nerve membranes. What I should have said is an anticonvulsant or membrane stabilizing agent, not one of these. It's tomato.
Okay. Thank you.
I have nothing else to add. I'll be happy to entertain any questions. Yes.
What do you think about marijuana?
Dude.
I'm serious. I have a niece it took years to get this diagnosed.
Mm-hmm.
And was on all the stuff. She's literally bedridden from the meds that she was on. Miserable.
Sure.
Like 10 years later. And somebody had heard somebody say that marijuana was good for it. And they brought her some marijuana, and she said, Aunt Trudy, for the first time in 10 years, I can actually have a belly laugh. And I know that in Michigan, there's two groups that will write, you can give prescriptions for marijuana based on chronic pain. I mean, it was cancer first, but then they went into the chronic pain and all that. But the problem with that is that then you have to be registered, and then you're this marijuana criminal out there, and when you're going to try to get a decent job or something, this is all on your, or follow-up and back, and, but if it helps somebody, if it helps them, and you don't have to smoke it. I mean, I can't imagine smoking something that smells like rotten hemp, but they have elixirs and they have powders and all these sort of things.
Dronabinol liquid's been out for years. Dronabinol is one of the key compounds in THC, tetrahydrocannabinol, and it's been around for years. It's treated specifically for the wasting, the lack of appetite in patients with terminal HIV. It basically is like giving somebody a bunch of pot brownies. It gave you the munchies. But to answer your question, I had a patient approach me a couple of weeks ago for the first time saying, is that something you prescribe? And no, it's not. Not because I don't believe in it, just because I prescribe chronic opioids. I prescribe opioids in high doses for chronic non-cancer pain. So I'm already on the grid, if you will. I'm already under being viewed with kind of a raised eyebrow, I'm sure, by if not at the Oakland County level, maybe at the state level by state police. So I tend to tread very gently in those waters, not because I don't believe. I believe wholeheartedly. I believe if it works, God love you, do it. But the one problem I have seen with medical marijuana, and I only seen a few patients, and that is there's a tendency again to it's hard, especially with you smoking, it's hard to titrate between a good treatment effect and a side effect. I have a patient, a friend who has a significant other who had severe chronic back pain, and he stumbled upon medical marijuana, and that was going to be his next line of work. He couldn't paint anymore as a painter, so he was trying to get a certificate to grow dope. He was going to sell it, but he actually got going, and then he basically started smoking up all his profit. So it's a problem. It's until their guidelines come into place. Right now the fact that I think either Royal Oak or Ferndale. Now Ferndale just recently voted yes to allow it for actually for recreational use on private property. It still doesn't mean diddly squat. The feds in the state say no, you can't. So Ferndale PD will turn a blind eye to you, but, Oakland PD will roll, Oakland County Sheriff will roll, and they'll say, I don't think so. So it's,
Oh, the state hasn't approved it, huh? I thought it was voted on, no?
no, the state still hasn't
No,
approved
okay,
it.
still state.
And even if the state has, the feds,
Feds are still, I
federal law
know.
still, trumps anything.
Wasn't there talk, though, of Obama or Department of Justice changing their views on that? I heard that on CNN or something.
Talk is cheap.
Yeah,
There's only two
yeah.
states that it's
Oregon?
legal,
Oregon and Colorado.
Oregon,
Yeah,
Colorado,
yeah.
Did you have a question?
I'm on Neurontin and Eleville,
Mhm.
and I haven't had a pain since September. So can I be on these long-term, or
Absolutely,
can I?
absolutely.
What exactly, what do they both do?
What do they both do?
Yeah.
Neurontin is a classic anti-seizure drug. It basically acts the way I said earlier. If you think of, a nerve, the nerves that cause trigeminal neuralgia, thinking like as a short circuit, neon sign going before it buzzes out. What the neuron does is basically calms that down. It takes the sign that's flashing and makes it just act normal again. Eleville is an old antidepressant drug from years and years ago. It affects the levels of epinephrine and norepinephrine, which are which are nerve transmission agents in the brain. It alters the level of neurochemistry in them. The way it treated depression was by increasing the levels of adrenaline and noradrenaline, which basically improved your mood. Eleville's a horribly underprescribed drug. It is so useful. Again, it's not for everybody, but for chronic pain, it can be exceptionally helpful. It's in some patients. So yeah, there's no reason whatsoever, as long as your primary care doctor is comfortable, neither of those drugs really having abuse potential to speak of. And as long as you're getting it like every 6 months or once you're just having routine blood work done, none of them should have any potential to cause problems with your heart or your kidneys or your livers, but just keep an eye on those things and you should be fine. You look very, very familiar. Any other questions? Yes.
Me and an oral surgeon, do you ever have like a scan to check for bone infections?
I just realized I couldn't do that. Do I scan for bone infections?
She had a bone infection.
Right.
Actually, she was a patient of yours. And I appreciate what you did for her. But anyways, she had a bone infection, and I still believe there's still a bone infection 3 years later. She had an ulcer, she had it surgically removed,
Mhm.
and now she gets little bubbles over there, and she says when they pop, they taste really nasty.
Mm-hmm.
So I don't know. Actually, I can tell you really what she said, but.
It wasn't nasty. It was a word like that, but we can't repeat it
Yeah.
here. This is a family show. Yeah, okay, I got you.
But I've taken her for alternative meds, and they have muscle tested her, and they said there's still an infection there that no scan will pick up unless you have a particular scan. But they do believe that she still has infection.
Well,
I mean, why would she get an ulcer? Why would she get these bubbles on that side? She was never, ever on IV antibiotics with a bone infection.
if she was if someone actually diagnosed her with a bone infection,
Mm-hmm.
the way I approach it, and, if I did not do, so in your case, had I not, I
You
apologize.
did a diagnostic block on her to see if she
Right,
had
exactly, and
TNA.
remember, it didn't really help anything, as I
No,
recall.
you woke
Right.
her up and I almost passed out.
Right,
She was
I remember that, that's right. If someone said she had a deep bone infection, the way I would approach that, again, if I didn't do that in your situation, I terribly, I apologize for being, lax. What should be done, honestly, most appropriately, is refer you to a good infectious disease specialist. That's the most appropriate way to go, because I have no qualms, no problems whatsoever with seeing an alternative therapist. Someone who, but if they're going to do some sort of muscle scan, they say, oh, the muscle scans, you have a deep bone infection. First of all, a muscle scan.
No, she's saying, or he's saying that there's still bacteria. They can pick up bacteria in her jawbone.
Okay, all right, I'm not going to question what mode they're using, but the only way to really truly detect if there is an indolent lingering infection would be in the hands of a good infectious disease specialist. And there are specific scans that can be done using different radioisotopes that look for various types of infection. which are exquisitely sensitive. You know, referred to as nuclear medicine.
Nuclear,
They'll inject a radioisotope. They'll actually take some of your blood out of your body and take the white blood cells, which are the cells your body uses to attack infection. We will actually tag or mark them with a radioisotope, inject it back into your body, wait a while, then do a nuclear scan to see where that goes. If there's no infection, it'll just go all over your body and it won't light up per se. If there's an infection, when they put you under a nuclear medicine scanner, that area will light up like a Christmas tree, and what they'll say is there's a hot spot, and that hot spot is where the problem is. I know, I think at one point the issue was one of, and I think Tim may mention once the idea of this condition called was it NICO, necrotizing
Yes.
cavitational osteonecrosis, which has always been a very hot topic. You know, it's been very, you know, I'm not going to say, I'm going to stay moot on this, was my opinion, but you know, the only observation I have is there's been more data that says we don't know. There's data that says that it's real.
Did I put you in touch with Doug Foley? He's kind of our expert on NICO. You know, those nuclear tests, I had that here at Beaumont and at Mayo Clinic. And I think with my brother-in-law in Milwaukee, and I'll never forget, I left Beaumont and I talked to one of the techs and they said, well, everything lit up, so we didn't know what the issue was. So that's, you just mentioned why.
Tim's always lit up.
Yeah, I'm always lit up, yeah. But I never
That's
knew
where
what
the
that
blush
meant.
comes from.
I thought if everything's lit up, there must be infection throughout the body, but
No,
what
if
you're
everything
saying
lights
is...
up, it just means you've got the tracers distributed everywhere.
Right,
You know,
right.
what you look for is one hot spot.
Yeah, they didn't
And
find
that's really truly the way to determine it.
That's in the bone though, right?
That's in
See,
the
mine
bone.
was in the nerve at the time, so that's why it didn't light up. The interesting thing...
NICO specifically is addressing infection in the bone.
In the bone.
That's what this alternative
Yeah.
that I had said possibly.
Yeah.
Tell them about the oxygen.
She was getting, through alternative med, oxygen,
Okay.
what do they call it? Ozone injections.
Ozone injections?
Mhm.
Okay.
And they said she still has the infection. She got 5 of those injections.
You have that picture, I was looking for that picture of what her jaw looked like. I don't know if she had that when you visited Dr.
I
Vallerand or
think,
not.
yeah, you did. You showed. I've
Did you?
never seen
You've
that.
seen
Yes,
that?
I
Yeah,
did.
yeah.
There's no question there's something going on there.
That's after the wisdom teeth were removed, right?
Right.
Yeah.
That, given,
That was after one of the root canals.
but as I
The root
recall,
canal.
the track record that you've gone through up till now certainly fits with there being some sort of, this is not like just one day it cropped up. It cropped up after surgical intervention of the jaw. Chronic infections of the jaw with conditions such as actinomycosis can, take months and months and months to show up, and it can sometimes take months of IV antibiotics to finally be treated. That's why a good infectious disease specialist is your
Do
best.
you have a name of one?
Where do you live?
It doesn't matter.
I'm just saying,
Around here.
yeah, around somewhere. I do,
There's Dr. Lerner here he's still practicing. When I went to Mayo and I saw infectious disease, they said, why are you coming to see us? Dr. Lerner wrote all the books that we follow. I guess he's at Wayne State, right, with his
Yeah.
wife. Have you heard of Martin
yes,
Lerner?
he is very good.
Yeah.
I was trying to think of this, I want to say Drelickman, but I'm mispronouncing his name. What I can do is, if you give me your email address, I will, because I've dealt with 2 very good ones in the Providence system, if you like. Some people like Providence, some people don't. But I've dealt with 2 excellent IT people in Providence who've, worked with the patient with facial infections. So, jot me down your email address and I can drop you the name and numbers.
If you want to talk to anybody about NICO, this guy is Foley, JD 2002 at Yahoo. FOLEY JD 2002 at yahoo.com. This is just one of our members who pursued NICO. There's somebody down in Ohio, I think, that specializes in it. I know you're a little on the border on whether it's a true, real condition or not. We've talked about that before,
Exactly.
I know, yeah.
If you have this, who might say it's not a real condition if you have it?
If you have it,
What do
right.
I know?
Right, yeah.
But,
Sorry, go ahead.
yes.
Yeah.
The dope lady, yeah.
I've been really looking all over the place to everything I can find, because so far, the situation with my daughter is nothing much has helped her so far. And she's not a candidate for the surgery, because she has atypical. And I've read stuff about laser. I've found out that maybe that big thing that's polluting themselves down in South Carolina is probably more of a hoax thing than it is, but.
Living ourselves.
Huh? Well, they're promoting that they cure everybody that nobody else cures.
Oh, the laser, yes.
Yeah.
Cold laser and soft laser, the most recent, multiple study meta-analysis have shown it's about as useful as the copper bracelets were for arthritis.
Right,
It's,
right. Well, then the
and
other thing.
I know there's at least one person in this room that may or may not have gotten good results with it, but
Yeah.
I think a significant portion of it may just be a placebo effect.
Dr. Badai is here, raise your hand, who does laser here locally and has done it with Joyce, but he'll be on the agenda some other time. I know the TNA has the same perspective that you just mentioned.
But I'm also,
they're not.
I've always been of the opinion, if it works for you, don't let anybody cast their eyes askance at it.
Right.
If it works, by all means.
What
Yeah.
about ultrasound type of things, or radio frequency, or any things of that nature? I've seen a lot, I've been reading a lot about that too.
Well, radio frequency was used as a means of doing neurolysis. Radio frequency neurolysis, RFL, was done for years.
I was reading
for
about
the ganglion itself.
in Israel and in the European countries, especially Scandinavian countries, they actually have this ultrasound device, like sort of like a transducer type of thing, and it's similar to what we used in OB for fetal heart tones in a way, but it sends out some sort of, the waves, yes, the impulses, and what people do is they sleep with it, and it has like a Velcro strap, and they put it like on the side, over the face right here. And the reports that I've read, of course, and again, who knows?
You can't walk around all day with that on your face,
But
so
you wear
that's
it
the
at night
problem.
when you sleep.
And then it corrects
And
it
it's
for the
supposed
whole
to do-
day?
It's supposed to do something to help promote the healing of that whole area.
Has she tried strong
Huh?
meds before? Has she tried strong
Oh.
medications?
Yeah, she's been on all of the Lyrica and this stuff, and the Tegretol.
Well, that's the anticonvulsants, but
Yeah,
I'm talking
she's
about
been-
pain
She's
meds.
been on, Vicodin and Percocet, along
But
with the
to
other.
answer your question, I think, the use of ultrasound and even, laser, I think there's the benefit there isn't so much, and again, this is my opinion, is that it's not so much curative. It certainly helps the same way that, infrared heat does. It is very soothing. It will definitely calm the system down. And the question is, how long of an effect are you going to get for it? That's the whole thing. Because the people that I've seen that have gotten good results with laser, you have to stack it. You've got to you can't just do it once and walk away and say, hey, I'm all better.
Right.
It doesn't work that way. It's just like using TENS, for some muscle pain. You've got to use it continuously, and you've got to find the right combination of pulses and frequencies, and then it will work. But again, it's for some people it does, and some people it doesn't. So you can't have somebody come in here and say it doesn't work. When I look at the data on it, the data says that laser in and of itself doesn't work. But I've also seen numerous patients in my practice when I was in Newark. There was an Asian doctor there who got phenomenal relief with patients using what he called cold laser. But how much, whether it's curative or whether it's more, you're decreasing the inflammation, you're decreasing the pain, and hopefully by doing that, at least with some musculoskeletal pain, you're breaking the spasm inflammation cycle. You can actually calm things down. I don't know how well that's going to work for nerve pain, because the exact nature of the inflammation, I'm not clear on. I don't know how much neuroscientists know, but
Well, my understanding with the atypical is that it's not going to get better.
well, atypical, quote unquote, ain't going to get better, nor is really classic TN.
Right. But then the goal is looking at all of these drugs. Like she says, Mom, I can't live on these drugs. This is not living.
Okay.
And so we're looking at alternative things to find a way to cope with the process so we can get off the drugs.
Absolutely.
And so that's why we're just looking for, any of this type, any type of exploratory, any type of thing that, if, maybe it isn't gonna take it away, we know that, but something to help, because these drugs, I'm telling you.
Well, see, you're talking about the anticonvulsants. Just let me jump in here for a minute. Dr. Haddix, who diagnosed me initially at Emory, he told me at the time that he had a surgeon and a policeman fully functional on morphine, which I've been on 500 milligrams of MS-Contin, but I did go on disability, and Neurontin. But he had these, the surgeon was continuing to do surgery, the policeman was continuing to do his, and they were on high levels of opiates. I can't remember if it was MS-Contin or what. So that's the only reason I would challenge you when you say you've been on a lot. I know what anticonvulsants can do to you.
effects is a very good point. That is, I don't care whether it's an anticonvulsant like Neurontin or Lyrica, or even if it's an opioid, high enough dose with either of those can make you totally, comatose. So it's not a matter of, you can be on high dose opioids and do fine. A lot of people can't. Some people can be like I said, I've had patients that are on 4 grams of Neurontin a day, and they're doing fine. I have other patients, they get them beyond about 2,000 milligrams, and they're comatose. So it's a balancing act. And, like I said, I like to simplify things. As few drugs as possible, on as low a dose as possible, and any alternative therapies, if you found they work for you, by all means stick with them. But what I tend to tell people to hesitate with is there's a tendency when you've got a situation or condition, and God knows you're looking for relief for you or for a family member, to run to anything and believe, my gosh, it's going to work, because I had one patient recently had terrible results with acupuncture. She was miserable. I have another patient who I saw twice. Initially, I was treating him with medication. He found an acupuncturist, was treated by him, and he came back once to say, I'm doing great. He never came back. He's doing fantastic. So everything works. What I want to,
Yeah, well, she's had
end with this.
acupuncture.
Everything works for somebody some of the time. It's a matter of finding what it is.
Acupuncture does diffuse the pain, so it isn't so intense, but you have to have it like every week, and it costs $60, and insurance doesn't cover it,
Yeah, unfortunately, you're going to find that with just about anything, whether it's acupuncture, whether it's laser, whether it's aromatherapy. You'll find something that works, and unfortunately, more often than not, some component of it's not covered.
Yeah.
And then you get frustrated, say, well, can't we find something that is?
Magnets, she wears little magnets when she's home, when she sleeps. She puts these magnets on her over here, tapes them on with paper tape, and it helps diffuse it.
If it does, don't let anybody ever tell you that doesn't work. If it works for you, it does.
Work and end up with magnets taped all over my face, with people thinking I'm sort of I said, who cares what they think? If it helps, who
It
cares?
works, yeah.
What's
Okay.
the upper limit for Lyrica?
Excuse me?
Lyrica, upper limit for that?
I apologize, I've got it real bad here.
Lyrica.
I've got my drug.
Upper limit for Lyrica, Doc.
Usually 600 twice daily. Yeah, 1,200.
1200?
About 1,200 maximum dose.
So it's less than Neurontin, huh? Much
Yeah.
less than Neurontin.
Does anybody take that doesn't feel miserable on it?
I take Lyrica.
Do you?
I feel fine.
What do you take, Frank?
Yeah.
How much? 1,200?
No, I don't think
How much do you take?
it depends on how much my pain is, if I have it all day, I just,
Take how
The thing
much?
that's interesting with both Lyrica and Neurontin is that, once you're on a therapeutic level and it works, it's really okay. I have patients who take it up and down because some, they have bad days and they find if they increase another 200 milligrams here or there, it makes a difference. If you've got a good enough level, you can titrate it up and down. And it's like playing with a thermostat. You can really get a good feel. And
Okay.
I'm sure a lot of you also know, when you're having pain, it's like, oh, this is the kind of pain that Lyrica is going to help. This is not the kind of pain that a Vicodin can help right now. And, it's different. You know your pain. It's different, from one time to another, which medication to take. I think some of the greatest frustration a lot of my patients had was when they took Darvocet off the market. I had one patient in particular, she was on a couple of Darvocet a day and she was perfect. She did absolutely phenomenal with her pain relief. And then they took it off the market. So, there's always a risk of that happening. You've got one sort of pain that'll work really well, and you've got to then worry about what happens if the drug goes away.
Pull up, yeah.
Anyway, anything else I can tell anyone? Yes.
I just, a couple things. Have you ever used Cytotec with any of your patients?
Cytotec, misoprostol?
Right. I know it sounds crazy, but since it's a
Well, misoprostol is normally used
for ulcers, right?
It's used Arthrotec was a medication that was out several years ago. It was a combination of misoprostol and a very potent anti-inflammatory drug.
Okay.
And the reason for misoprostol was specifically to prevent it helped increase the mucus production in the stomach
Okay.
to prevent ulcers from it.
But because it's a prostaglandin E analog.
You cannot use it.
It does,
Exactly.
It does help with pain. It was something that they discovered from the TN group way back in 20 years ago.
Interesting.
Yeah, and you talked about that one patient of yours with that stabbing eye pain. You ever used Toradol with that patient?
Yeah, we've tried Toradol, we've tried.
That was the only thing that helped me when I had it, but then I had the MBD and after they did the decompression, I don't have that standing pain anymore. So it was most likely a compression.
Yeah, the one drug I have a lot of hope for, it's in the pipeline right now, is trigemina.
Do you really think, because we haven't heard on it.
She's telling me it's a sex hormone
Well,
drug.
oxytocin is Pitocin. It's vasopressin. The body makes it. It is used for everything.
It is.
But it only lasts, like, it's very short-lived, isn't it? They're saying the onset.
Well, if it's a nasal delivery, you can run around with
It's
it.
like Stadol nasal spray. Stadol nasal spray is short onset too,
Yeah.
but
Yeah.
oxytocin's phenomenal because it's used for everything from inducing labor. It's also used for treating some forms of von Willebrand's disease. Patients with bleeding problems, you administer that
Autism.
before they have surgery, and it increases the release of platelets from the blood vessel walls, decrease bleeding. My son was on for many years oxytocin nasal spray for nocturnal enuresis, bedwetting. This is like it's like the old in the 1890s we'll guarantee to grow hair on a billiard ball. So let's see what's going to do next. Rub some oxytocin on your car with your ShamWow. Look at that shine.
It's cheap.
It's cheap.
Well, we'll see. It's cheap until it comes out
That's
in
right.
in a branded form, and then it's not going to until it goes generic. You're going to pay the bad analogy, but you're going to pay through the nose for it.
Yes.
They use Cytotec for softening cervixes and inducing early labor. too.
Absolutely, yep.
Yeah.
Absolutely.
That's
I
good
have a question
information.
about codeine. Back when I started in the dark ages, Emprin compound number 3 with codeine was a very common medication,
Right.
and it seemed to be very effective. Whatever happened? You used to be able to get cough syrup. Is it because it's of addiction? Potentials?
Well,
or why?
codeine is Emprin kind of went away. So did Fiorinol. You can
Yeah.
still. I have one patient who lives on Fioricet with codeine. Emprin was like aspirin.
Aspirin with codeine. basically.
Emprin was something else.
Yeah,
Emprin
yeah.
was a standalone codeine. It was aspirin phenacetin.
Yeah.
Phenacetin was an old aspirin type drug which they took off the market because it caused kidney issues.
Oh.
Yeah, it was aspirin, phenacetin, and codeine.
Well, why not just codeine? I know codeine upsets the stomach for a lot of people, but it was that cough syrup, terpenhydrate with codeine was the best cough syrup in the world, type of thing. And
Well,
now
there's lots of stuff out there that worked really well.
You have
My
to
father's
go over to
repair
Windsor and
work,
get it, I know,
which is
but
nothing
you
more
can't
than
get it.
liquid opium. That worked really well for him. I'm sure it did. But that was back in the 30s also. Codeine's still out there. You can get it in various formulations. It's it's like APC, aspirin, phenacetin, and caffeine was around for years. It was great stuff. They took the phenacetin off the market, and then you end up with aspirin and caffeine, which is basically anisine. The interesting thing is they put caffeine with a lot of these, it was Excedrin migraine. And the bottom line is caffeine has never really been shown to help with pain. They just kind of threw it in there, and everybody's kind of like, that's okay, so they use it,
I thought it potentially did.
Well, it supposedly does. It's never been shown, but it's one of those, it's one of the few drugs that's managed to get away with the idea of, we don't have data that says it doesn't, so let's go ahead and do it. It kind of got grandfathered in. One of the few things that other than keeping you awake, one thing the caffeine will do very well, it is a good bronchodilator. It'll help with asthma. So if you want to be wide awake and not wheezing, go to Starbucks. Your wallet will be empty, but you can go to Starbucks. All right.
Anybody else? Any
Thank you.
questions? Let's give him a hand. Did you bring any cards? Everything's plugged in. That's what the expert said, but I'll get it anyway.
And then they denied it to me because
What's it not doing?
that's a lie.
All right. Just continuing on here, I'll let Gary get up here in a minute. We talked about the intranasal oxytocin. Lynn, I think, has a little more to cover on that. I meant to, your note about Marcaine nasal spray, I meant to put on the iPad and I didn't. You want to address that a little bit?
Well, there were just some significant side effects with Marcaine. I wanted to talk about Jill too. She had the lidocaine intranasally through the cannula, but she didn't have relief after it wore off, and it was, I don't know what she said
She had the Marcaine or the oxytocin?
she had lidocaine.
Oh, lidocaine.
So they're using it, lidocaine, Marcaine. The Marcaine was in Chicago. They were doing a drug test there, a clinical trial, but and that's still ongoing. So they are working on this new avenue, shall we say, but,
Well, that'd be nice, you could just carry it with you, couldn't you? Just pop it in.
right,
It's not like taking a pill, so it'd be immediate effect, right?
right. Oh, it takes about 30 minutes from what I've read.
Well, what's it actually doing? What's the spray actually doing? Going into your
It's
lungs?
going into the, sphenopalatine, ganglion. So, it's a new avenue, hopefully, it'll be more promising when we know more, but
Okay.
at least
Jill's
it's
was a
something.
cream, though, we went up for her nasal passage,
Right.
and it was a cream.
Oh,
Is it
cream?
I'm pretty sure it was a
Spray.
cream.
I had the cream.
It's a spray,
Yeah,
because it's,
It was a spray, I
Yeah.
thought hers was cream, okay.
Dr.
She
Badai,
had
if you have anything to add
significant
during
side
this, feel free to speak up. Okay. Okay, you had some concerns about this oxytocin, right? That they weren't far, Bochi had some concerns, it wasn't far enough along in the studies?
basically, he just didn't put much,
Faith
faith in it, because it's
in long term.
it's not very long lasting. but-
Would a neurologist prescribe that? Or would you
Is
get
there-
that from your
I
doctor?
think you can get that now, can't you?
This,
The
oxytocin?
oxytocin.
Can
Yeah,
you get
because he
that
was
now?
using it for bedwetting, yeah.
you
Because
can
he
get
was
So you're-
using it for his son for bedwetting.
Oh, that's right.
So, yeah, you can get it.
And so your internist could give it to you, huh?
Yeah.
You wouldn't have to go to a neurologist, maybe that's why he doesn't
Right.
have much hope for it. I'm sorry, picking on Dr. Bush, but, yeah.
Yeah,
Wouldn't
so-
be, if you could replace the pills he's giving you, right?
Yeah. Oh, I don't think it's ever gonna compete with
No,
oxytocin.
You
or
asked,
no, not the opiates.
you asked me, we do like a cold laser in our office,
Oh.
and Joyce is,
Here, yeah.
she's with DN. She had pretty good results. Sometimes she doesn't even need to.
You're
use
talking
med-
about the laser now?
Laser,
Make
cold
sure we
laser,
missed that.
yes.
Yeah, okay.
Cold laser we are using, and, Joyce is one of our patients with TN, and,
She
sometimes
comes
she
in what?
has several days or weeks she can go without medication.
You go weekly, or you
Yeah.
go weekly?
Yeah, she comes weekly, yes. Yes.
What is it?
It's a cold laser we are applying, and at certain points in the jaw, upper jaw, lower jaw, it depends where the problem is,
Like a
with the.
tube in the mouth type thing?
No, it's not tube, it's a outside, it's a red light, pretty much, it's non-invasive procedure, and you just apply laser, at least, for 30 seconds on each point, there are, probably up to 5 points that we, activate. And then what it does, it helps to calm the nerve down. It increases microcirculation with the nerve, and then helps to get more nutrients to the nerve, and it calms it really down.
What kind of doctor are you?
I'm a chiropractor. We do nutrition too. Yes.
You don't do NUCA, do you?
What's that?
NUCA?
No.
You don't do NUCA?
No.
You do any of that sort of thing?
No.
Different than NUCA? You don't, okay.
You put a cage over her hand?
No. It's pretty much looks like a tube, and then we apply very gently that.
You don't have no cage.
No cage.
I guess I
If
covered
someone
pretty much.
wants to try, we can give you at least one trial to see if it works for you, because it may not work for everybody. So what we offer, I just mentioned to this lady that first treatment can be at no charge. See how you respond.
Where are you located?
We are located in West Bloomfield on Maple, just west of Orchard Lake Road. I have cards if you are guys interested.
Yeah, we have some cards over
Yeah.
there. You're headed toward West Bloomfield, just before you get to that.
Okay.
Yeah. Okay, here. I talked about the thing again. I really stress that. Read that article, and it's online, and somebody pointed it out in the TNA Quarterly, Finding the Perfect Doctor. It really kind of tells you everything from A to Z about the things you should think about when you go to see a doctor, especially a new doctor. There's another article that I sent out to you. Hopefully those of you who received the agenda online. Did somebody here get it online? Did it all come through? It all came through, okay. I got this, my web TV went away, and I went to something called Outlook, so. I have
Yeah,
to-
one was blank, and then the next one.
Yeah, there was, I don't know where the two blank ones come from. I only put it in, there were 4, right?
Yeah.
2 blanks.
No, but I got 2 emails from you. One had absolutely nothing. And
Oh,
the
yeah,
next
that was the
email-
first one I sent out, yeah. You were in the first of the 4 waves that nothing was attached.
Yeah.
You were my test. I don't know, it worked better last month. I guess I got to write down what I do, because 30 days later I forgot, so. We covered the financial status. We don't have any new members. Again, the 7 new definitions that Dr. Vallerand referred to, we've got copies of back there. Oh, I know what I wanted to cover. I keep going here to push it up and forgetting that I got it here. You want to have a holiday celebration for December? I put that down.
Yes.
The ladies usually want to have that.
Do you, Lynn, want to pass it on?
I'm in Atlanta until the summer before that, but I'll get a letter prepared. If you let me know a little bit about what you're planning, I'll prepare a letter now that we email out. For next year, I've got Dr. Kramer, the Nuka chiropractor, is in January, February discussion only. Dennis is going to come. He talked to the replacement for Dr. Copeland. I see, Dr. Benet, you've got a copy of the Copeland thing?
Yes.
I can tell you a little more in detail without putting it on camera what happened. That's his nurse coordinator, and he said if he comes and he talks to Dr. Jones and he tells him he's coming, maybe he'll come with him, because he didn't act like he had an interest in presenting like Dr. Copeland did, so we'll see if we embarrass him into it. The other ones, those are all our dates if anybody's looking for them. I need to talk with Malik and Piper for sure. Raina Instop, she's called and said that she's, does anybody go to her here? Neurologist, I think the Peters go to see her. I saw her 16 years ago, and she didn't diagnose me, but a number of TN people go to her. We've been trying to line her up. Is there anybody else that, I don't know if we need to get Dr. Guith again or not. Not many people go down there to see him. I think it's mainly Malik and Piper, and now we've got Dr. Casey did an MVD downriver, and she was very high on both his hospital, Kathy LaForest was, on both his hospital and, I have my note here, and his ability, because she's got no pain. That's amazing. That's probably our best case. First damn meeting she comes to, she hears a neurosurgeon, she goes and has an MVD and her pain's gone. I mean, it can't get any better than that. I wish all of our people that come to our meetings for their first meeting, we could have that result.
Wear quacks.
Hmm?
You wear quacks.
Yeah, yeah. You wear quacks. Yeah, you saw a number of them, right? Yeah. And these are all, we won't go over all that. For your reading, now look at that, comes out so good. I don't know why that didn't earlier. Cut that, Gary. I want to call you Dennis or something. All right.
I got my notes with me.
There you go.
Give us a lecture.
This man is Gary Goodman, one of our members, who is used to be in severe pain.
Used to be in severe pain.
You're on.
Started about 2.5 years ago. I was brushing my teeth one morning, and I got to the lower jaw, and I got this shooting electric pain, electric shock, and didn't think much of it, you know. So next day I was brushing, and I got the same pain. So I thought I better go to a dentist. I went to a dentist, and I told him about this electrical shock. And he checked and he tapped all over, and he says there's nothing wrong with your teeth. And I went home. And I avoided brushing my teeth in the lower jaw for a few weeks, and then I just start getting close to the area, and then some mornings there was no pain, and other mornings I'd get the shock. And so I went and saw a specialist. And an oral surgeon, and he had thought, you know, he went and did the tapping on all the teeth, and there's nothing wrong. So, and you know, so then the pain went away. Pain went away. And, in May of 2011, I had a disc removed from my neck.
Oh, that's right.
Did a surgical operation and removed the disc, and while I was in the hospital recovering, this pain came back. And the only thing I could eat was ice chips, and it was the ice chip. It was as soon as I put the ice chip in my mouth, the pain, and then it went away, and I just didn't eat any ice chips. That's all. And so then they're getting ready to discharge me, and I says, I can't go home. Can't go home with this. Whatever it is, I can't go home with it. And the surgeon out of St. John, fortunately, had a physician's assistant that said, well, what happens and what happens? And so I explained to her, and she says, you have trigeminal neuralgia. And the surgeon didn't know that much about trigeminal neuralgia, but fortunately his PA did. And they prescribed me some Tegretol. So I took 100 milligrams of Tegretol in the morning and 100 milligrams in the evening. And some mornings I had pain and other times I didn't. And then it got more frequent. Quickly got more frequent. And so I started going to neurologists who would tell me I needed to avoid talking, eating, and stress. Talking, eating, and stress. Oh, this is great. And oh, and by the way, here, take some more Tegretol. You know, so that's the way I lived for a few months, and the pain just kept on getting worse and worse and more frequent. And I went to more than one neurologist. I went to 9. I was looking for someone to tell me that I didn't have this. That's all I was. I didn't know. And they all said, and some of them, when I told them what I had been diagnosed to have, I'm sure some of them left and they went and looked up some symptoms, and then they came back because they weren't that familiar with trigeminal neuralgia. That's the way I went through life for the next 6 months, and some of the episodes were very short, 2-3 seconds that seemed like an eternity. And one time I went to an oral surgeon, and he did a root canal, okay? And because I finally found a guy that he said, I got a test that will prove whether you have trigeminal neuralgia or not. And he put the shot in the jaw, okay, and he waited for an hour, and he says, well, have you had any of the trigeminal pain? And nope. And he says, then you don't have trigeminal neuralgia. Let me just take care of that too.
That's a test we don't know about.
Right. He said, just let me take care of that root canal. And they did a root canal. And I felt so good going home that night, knowing that I no longer had trigeminal neuralgia. So I decided to not take the Tegretol that night. And that was the worst night of my life. And I had a short episode that I banged my head against the kitchen counter and ended up at St. John Hospital and in the emergency room, and they put you in a little, they don't know what to do with you when you get in there. You know, they would come in and say, oh, what's your pain level on a 0 to 10? And it's either a 0 or it doesn't fit on your chart, you know, it doesn't go 2, 4, 6, 8. And so I kept on taking more, and that's when I went out with seeing Dr. Casey, and I tried to, his goal was pain-free. And I thought pain-free, I didn't really know what pain-free meant to them. I knew what it meant to me, but I didn't know what it meant. And we kept increasing and increasing, and I was finally up to taking 2,400 milligrams of Tegretol.
Wow.
And that was on a normal day, so 2,000 some days, 2,400. And plus, I just some days I take a little less, and some days more, depending on the test in the morning was brushing the teeth, you know, and and it got to be too much, you know. I couldn't live like I'm supposed to function, okay. I'm working as an engineer for one of the automotive companies, and I got certain responsibilities, and I wasn't doing a very good job, and I still needed to work. And I get tired of losing my car in the parking structure. And I parked it in the same spot every morning, and when I go there at the end, it wasn't there. And I just couldn't understand who moves my car during the day. And I would go up and down, and I'd hit the thing, and sooner or later I would stumble upon it, and there'd be some cold in January is the worst time to lose your car in a parking structure.
Right.
And,
We
and
got you
besides
better.
that, there's 250
Or
black
January.
Chrysler 200s in the parking structure, you know, and they all looked like mine, but none of them would open, the doors wouldn't open. But, you know, the episodes at night got so severe, and they started to last longer. And, you know, I read the book, What Time Thursday or whatever,
Yeah.
Tuesday, is it What
Tuesday.
Time Tuesday?
Yeah.
Only we could understand what that meant, you know. There was one time where, so these 20, went from 2 seconds to 20 seconds to probably 4 or 5 minutes.
The bouts,
The
pain
bouts,
bouts.
the pain bouts, and in one in the middle of the night, and I remember thinking it was not going to end. And I didn't think about killing myself at that time, but I thought of, I could see, here's the thought, I could understand why someone would go into that kitchen drawer and grab a knife, but I wasn't thinking about doing it, but I could understand that someone could do that, because I didn't think the bouts were going to end, you know, and so finally we went and through this, we had gone to see Dr. Malik after 6 months, and he says, well, you know what, when you get ready, you know, and he had me do this test. He had me walk this line in his office, and I haven't had a drink in 23 years, and I don't remember I couldn't walk the line, you know, and I thought, you know what, that's how. So I thought I was functioning, and I could just imagine what everyone else thought.
What your wife thought, huh? Yeah.
Well, the thing is, the avoiding stress. My wife, I said, wait, we can't go there. We can't. She want to argue about it, but we can't argue. Remember, we cannot argue.
That's the good side of having it, huh?
Yeah, but it wasn't. So anyhow, I think we went back and saw Dr. Malik and scheduled the operation, which I had done 5 weeks ago.
MVD.
5 months ago.
The
5 months
MVD.
ago. MVD. June 13th. Okay, so 5 months today. And you know, the 5 days, so 2 days in intensive care, and 3 additional days in the hospital, and you know, the preparation was, and Tony, Dr. Malik's nurse, he told me you were going to have headaches that you will never. How did she say? You can never imagine having headaches as bad as you're going to have them. So that was the preparation for. All right, I'm going to go get this done, and then I'm going to have these headaches beyond. And but she helped me through those, because for 5 weeks I had headaches worse than I could ever imagine.
What did they give you for that one?
I just took Tylenol. And it's basically because I could have had something stronger, but I have this addictive personality, and I didn't want to.
Yeah.
I didn't
Take
want
a
to
chance.
fight that battle again.
Right.
Okay. So for 5 weeks I had the headaches. The 4th week they started to get a little less severe, and the 5th week they just went away. And you know, today, so I went back to work after 7 weeks, and I haven't had a headache since.
Haven't
I'm
had a
still
sharp
taking-
shoe? No,
Oh,
no pain at all?
No trigeminal pain at all. I still take 200 milligrams of Tegretol. That's what I'm down to. Okay, so I went from the 2,000 to 1,000 to the 800 to 600. I'm at 200 right now. I take 25 milligrams of Elavil each, and I take them at night. And I know he's going to tell me, okay, you can quit taking them now, but it's kind of like a it's probably more a security blanket than a necessity right now. So, because I remember the last day I went without a Tegretol, and so I got this fear. There's still a fear, but one of these days I'd cut one in half and take 100 milligrams and see what happens. But you know what, the care at his organization, Henry Ford West Bloomfield is the most beautiful hospital in the world, you know, and the other thing is I owe it all to this group, because when my wife, I came home from work one day after I was about 3 months into this thing, you know, and couldn't find somebody to tell me, and I finally come to grips that I had it. And she says, hey, there's some people out there that meet in this, out here.
Well, she found us?
Yeah, she found this group.
How'd she find us, do you know?
On the internet, you know, and she calls you, and she says, hey, tomorrow night we're going to go to this, and you know what, trust me, I understand self-help groups, okay, so I was more than willing to come out here, okay, and to find out that, hey, wow, this is great, this is a great group, because you know what, I learned so much in here, you know, learned about the options, learned about what you know, the successes and the failures and everything else that was in here, and you know, that's why I still come here, because you know there's no guarantee that this thing's and yeah, you know what, there was a blood vessel that was wrapped around this trigeminal nerve, okay, so that's what the thing that the MRI doesn't show, and so he had to free some of the pressure, and then they wrapped it and they let the blood, so it's still there, the blood vessel's still wrapped and it's got the padding, but you know, so today, so I still come here, and you know what, and Tim gives out my phone number. I get calls from people, and I'm trying to tell you something. When my brother calls me, I don't return the call that right away, but you know what, when somebody calls and there's a message and it says, hey, my name's Roger and I got your number from Tim, all right, I'm calling Roger right away. You know, because I know what these people, I know what we have to go through before we get some help. You know, so that's why I'm still here tonight. And, thank you to everybody for listening to me.
One place all the time?
Yes, always in the same tooth.
It never changed?
The same tooth always bothered me. Yeah, never went up, never went down, never went forward. Right in the same jaw, lower jaw.
Instead of brushing your teeth, I use the water pick.
Yeah, you know what, I thought about doing that.
Did it trigger anything?
Thought about doing what?
Well, it does, but
water
put it
pick.
on lower pressure.
Oh, a water pick, yeah.
So it's not like a brushing your teeth, like I got brushing.
Use a water pick.
Use the water pick. Better.
Well, you know, you're telling that story not only for this group, but for all the people that will review the video online on the internet is excellent. Not only, you know, attributing to Dr. Malik, because we've got the other 3 neurosurgeons here as well, and Lynn and the 3 ladies who reported out, must have been November 2010 then? Was it that long ago? We had 4 of them lined up here that had the MVD by Dr. Piper that were all better. So we appreciate your reporting out on it.
So nice to have you share.
Thank you.
I'll let that run for just a minute. I did have a letter from Kathy LaForest. I promised her I'd read it. Dear Tim, I can't thank you and Jill enough for all the time and help in the FPA TNA support group. I attended my first meeting in September when Dr. Casey spoke. On October 24th, Dr. Casey operated on me for TN. Thanks to you, Jill, and the support group, I now have relief after several years and many doctors. The pain is gone, underscored. I will be back sometime next year. In the meantime, keep up the good work. Yours are my prayers. Thanks again. Kathy LaForest.
Wow,
That's great.
Anyway, it's good for anybody that has a procedure that continues to come back, because they can report out not only on video but to the people that are here. We don't have any new members here tonight. We usually have 2, 3, 4, and we have some meetings where we don't have any new ones. But at least the videotape is available, hard copy, to people that can't make the meeting. I think I might have mentioned, we used to send out 34 the last month before we stopped. And since January, TNA has now hired somebody in Denver that puts them online. And it's really easy to pull it up. Even I can pull it up. Did you get that? My advisor here, from a technical standpoint, even his daughter was helping me get online today, so I appreciate that. Any other questions of Kim?
No, you know, I wish the person who was sitting behind her, the woman she left just a little bit ago, when
Yeah,
she
who was
first
that?
came in, I had not seen her in a long time.
Oh, that's
She's
Diane.
also getting laser therapy.
Oh, she is?
Yes.
Where?
I did not ask her, but she said that it has saved her. Did
Oh.
she tell you, Lynn?
I know that that's Diane.
Diane.
Is it Diana? Hope, did she sign out the, she signed the paper? I know I recognize the
Yeah,
face.
I
She
gave-
said I haven't been here in a
Yeah,
while.
She gave me the paperwork, so I think
Yeah,
she
because I
signed
gave
it.
it to her.
Oh, okay, okay.
I haven't
If,
signed it.
if anybody else wants to talk to her,
But she's also getting it.
the laser, and it's working. She's getting it locally. She doesn't go to South Carolina, right? She gets it here?
Somewhere in Michigan.
Oh, okay, okay.
She's
She wasn't your
very
patient,
happy.
Doc?
She's been
You didn't
happy.
recognize her? Okay, anything else, Doctor, you might want to tell us?
So much, yeah.
No? I know I didn't ask you to, I didn't know you were coming, or I would have had you put something together. If there's anything else you want to mention now, feel free to, although we'll have you back and put you on the agenda and you can formally prepare your remarks.
I just mentioned, you know, patients, whoever wants to try it, at least, you know, they can come for free trial. We will give you free trial.
Do you get results first time?
We do. You know, yeah, usually patients, they do. They, you know, most of them, they noticed decreased pain and inflammation as well. Yeah. They
So,
do.
like Dr. Vallerand
Majority
said,
of patients.
it's, you never know until you try it, you know?
Yeah, but I didn't know if it was like hematology, if it took
Yeah.
more than one.
Yes.
Yeah, yeah,
Yeah, sure.
yeah.
Well, isn't it supposed to promote healing too, with the
It-
improve?
It will prove, because it actually increases microcirculation,
Yeah.
so it actually helps to heal the nerve. But
Yeah.
like I said, you know,
And it's a
uh,
slow
when
process,
Dr. Bauer-
because the
yeah,
nerves
exactly,
heal
Sport- yeah,
slower.
exactly, because nerves it heals much slower than any other tissue, so,
Yeah.
Yeah.
yeah,
Yeah.
especially when it's damaged,
Yeah.
so it's not just quick fix.
But the
Yeah.
theory supposedly is if the nerve hasn't healed in anywhere from 6 to 12 months, there's a good chance it's not going to. Is that your
It still
theory?
can be, it still can be, because we have patients also with neuropathy, and we applied laser, and they respond really well, so.
Is that the main application for it, neuropathy?
Well, neuropathy is one of the
Yeah,
applications too,
okay.
yeah, it's one
Yeah.
of the problems. We
Yeah.
treat, you know, several problems. We treat also patients with acute injuries, we treat,
Oh,
you know,
okay.
we have athletes who have sprains, you know.
Oh, and it helps the
ankle
circulation,
sprain, yes.
yeah.
And they are back, after 2 treatments, they are back playing.
Yeah, yeah,
So it's a variety of, you know,
yeah,
you know,
Yeah.
applications, so
Yeah.
one of them is trigeminal
Yeah.
neuralgia too. So.
okay. Anything else? Again, Gary, thank you very much. Thank you for all the people that'll be reviewing this as
No,
well.
with this one is no.
Take care.
No.